Welcome back to Medical Monday. Sure glad you're with us tonight. I'm here with Dr. Jack Erter from Tennessee Oncology. We have Regina on the line. I don't like to keep our callers waiting. So, Regina, what's your question?
Well, first of all, Happy New Year to both of you.
Happy New Year to you.
Thank you. You too.
And my question is, polyps in the uterus, how often, if you have them removed and notice they come back, what's the cause of that? And how can one eliminate them coming back altogether?
All right.
Okay.
So the cause for the vast majority of folks is usually going to be an interaction of two things. One is the environment of a given organ. So where we see polyps most commonly is in the colon. And most everyone, at the age of 50 is recommended to get a colonoscopy for that reason. And that is partly due to the fact that there's just, things traveling through our colon all the time. Likewise, the uterus is to some degree has a certain amount of exposure to the environment, compared to, let's say, your heart or your liver or something like that. Secondly, each of us has a different genetic signature and a different genetic susceptibility to certain things going awry. And so some people are just going to be born with an innate propensity to have more, polyps as the case may be, or, other types of growths or abnormalities. And some of it really is just how we're built. And so, in terms of prevention, I think that the biggest thing really is regular follow-up with, in this case, your gynecologists, and making sure that these things are being kept an eye on. But, I don't think there's not specific, medicine to take or anything so much as monitoring and as needed, minor surgery, that kind of thing, yeah.
Okay. All right, let's go to Thomas. Thomas, thank you for being part of Medical Monday. What's your question?
My question is, and everything, that last November I had at 14, I had a massive heart attack. And Vanderbilt's done a three-way bypass, and they said,
Thomas, did we lose you?
no.
Okay.
And I've got my whole heart and vascular system is clogged up with asbestos and dust. And I was just wondering whether that would be considered a blood cancer.
Thomas, I'm sorry to hear about your recent medical issues. So the asbestos part, certainly that is associated with a very specific problem, which is a type of a lung cancer that most of us have seen commercials about this, called mesothelioma. The asbestos in the blood part, I don't think you necessarily have a blood cancer, but certainly I think you've had a toxic exposure in the past, probably related to past employment that I think certainly had something to do with the heart attack and vascular issues you've had.
But don't necessarily be worried about the blood cancer.
Correct.
Okay, that's a word of relief. Before we took a break, we were talking about it, and you just really piqued my interest when you said a lot of looking at the genetic. I don't know. What's the word? A genetic component of cancer, and maybe where there's a shift in something that you're doing or something that happens internally, and then cancer comes up.
Right.
Talk to me about that. Where does that play in the game now?
So certainly we know that it's generally a DNA level problem that leads to most cancers, and there's some cancers where we can easily discover what that is, and some where it's very difficult to find. And a lot of that is due to the fact that our DNA, our chromosomes, that system, while on a certain level is kind of simple, if you've ever read much about it, on another level it's extremely complex, and that what we understand is probably somewhat rudimentary compared to what's really going on. With that being said, there are certain things that are happening at a cellular level that are clearly causing cancers to come up. And so one very easy example is that there's the most common type of leukemia that is seen in the world is called chronic lymphocytic leukemia, and we call that CLL. And there are certain genetic changes that we see over and over in CLL, and a couple of them are very bad acting. They tend to be very aggressive and not respond to standard therapy. And one of them is when a person, their cells are dividing and they lose part of their 17th chromosome. And when that happens, it leads to CLL and leads to a very bad acting CLL. But we see that come up in America, in Europe, in Asia. It's something that is clearly happening on a very basic building blocks of us being humans level. And, we're clearly, as we start to identify, okay, you have this, it's not just that you have CLL, it's that you have this type of CLL that was caused by this genetic change, and that we need to treat it a different way. And that's something that really, again, 10, 15 years ago was not as well understood as it is now.
So really, it sounds like you are drilling down and saying, okay, this is, component by component by component. We're tracing it back and starting the treatment there.
Absolutely, and that is true across the board for different types of, lung cancer, breast cancer, et cetera. That's really true across the board.
I've always prescribed to the thought, if you treat your body well, it will be well. Now, you see marathon runners who get cancer or drop dead of a heart attack or whatever. These things happen. Talk to me in terms of cancer and getting cancer. Are there things we can do that are better for our body and I guess increase the odds that we won't get cancer?
Sure. So just like you said, I think that there are people who do everything right and they get pancreas cancer at age 40, and it's just not right, and that happens. But there are certainly some things that are very well known that all of us are aware of. So that would be not smoking, doing what you can to control. The buzzword that we use a lot now is inflammation in the blood, and so that's things like diabetes, cholesterol abnormalities, things that actually have a lot to do with cancer development in certain ways. And so, the healthier the better, and I think that's certainly been borne out in terms of, but there's a certain point at which we're all human, and that at some level, even when you do everything right, quote unquote, something can go wrong at a cellular level, and a cancer can develop. But that being said, I think aside from living a healthy lifestyle, I think the biggest thing people can do, and that even in this day and age gets overlooked or put off, is general screening and kind of adhering to those guidelines. So things like a colonoscopy at age 50. No one wants to do that.
Nobody.
I don't want to do that, but it's important. And I have definitely seen it firsthand save lives. Mammography as indicated. Things of that nature. This is pretty simple, low-hanging fruit, but it makes a really big difference.
It does, because the sooner you know it, the sooner you can do something about it.
Absolutely.
But it's scary sometimes.
It is. It's very much so.
Yeah.
I agree.
Especially you men. I'm going to stereotype here because I've heard it from doctor after doctor. Men are the worst about getting those physical exams.
It's very true. And and it's funny, a lot of male and female, but specifically I do think a little bit more on the male side, guys who just haven't gone in to see their doctor in years, and by the time they come in, something bad is wrong.
Yeah.
And that's when they end up coming to see me. And sometimes some of our options are limited because this wasn't handled at an earlier phase.
Sure. When you guys look at treatment at Tennessee Oncology, obviously you've talked about being in on the ground of groundbreaking research and different experimental drugs and being able to do different clinical trials. What about when it comes to when you look at the whole body and the spiritual side of it, the physical fitness side of it? Is that something you all look at too? The nutrition side of it?
Sure, and it certainly is. I think it's something where we have over the years tried various ways to implement that in our clinical practice, from having, and some of this are things that we still do, having a clinical psychologist and a palliative care physician on staff, to kind of help out with some of these types of matters. Certainly, we generally utilize things that are readily available in the community when it comes to nutrition counseling, things of that nature. For instance, in the community, through the YMCA, which we're partnered with through HCA and the hospital systems, they offer very focused, often free programs for cancer survivors and people dealing with that type of thing. And so these are things where we don't necessarily do it as employ a physical trainer or personal trainer in the group, but these are things that we certainly are cognizant of and try to steer people in the right direction, because a lot of that is already available.
Do you think it makes a difference in treatment?
I do, and I think that probably the two things that have the most bearing on how someone is going to do, just in a very global sense, is something that we refer to as their performance status. So when they come in, are they a pretty robust, ready to go person, or are they not doing well to start with? You know, that's number one. And number two is, you know, what is their attitude? You know, how are they going to keep mowing the grass and doing their normal life, or are they going to just shut down? Because, you know, when you just shut down during this battle, it tends to portend, you know, that things aren't going to go that well.
Yeah, mindset.
Right.
Big part of it.
Big part.
What about chemotherapy and radiation? Forever, that seemed like the benchmark of cancer. You have cancer, this is what you do. You have chemo, you have radiation. We'll see how it goes. Where does that play in the game now?
So in this day and age, certainly there's really three, you know, common modalities to cancer treatment. So surgery, chemotherapy, which is changing dramatically. You know, chemotherapy really doesn't mean what it used to. You know, a lot of the treatments we use for chemotherapy are not what you think of as chemotherapy anymore. And finally, radiation therapy. And those all still play very essential roles. Certainly, radiation therapy is something that you see used much more in solid tumors than in blood cancers, but it has a big role in certain blood cancers. For instance, we keep the word myeloma keeps coming up, and that's a blood cancer. It's mainly in the bone marrow, and people tend to have some painful bone lesions from that. And we can zap them with radiation, typically get very quick, you know, improvement in pain management. But in this day and age, you know, I think that what has changed is really the way we sequence these things. I think we you know, year after year kind of refine, you know, what is the role of each of these different modalities and how do we combine them to get from, you know, diagnosis to cure.
One thing, and tell me where I'm wrong here, but it just never made sense to me when you see someone with cancer, obviously their body is under attack from the inside out, and then you put them through chemo, which nearly brings them to death. I mean, it really is stripping your body.
Right.
Why does that make sense?
Right. So so two things. First is that chemo today versus chemo 20 years ago, and I know I kind of sound like a broken record on this, is just vastly different. Even people with the cancers you think of that they were going to just do so badly on chemo, so breast cancer, lung cancer, even those are much more tolerable today for a bunch of reasons. Some are the drugs themselves are better. Some of it is that the treatments we have to prevent, let's say, nausea and vomiting are a lot better. And so that's part of it. So chemo that sometimes we used to have to give people in the hospital because they'd be so sick.
Right.
We can do that in the clinic now. And so some of it's the supportive care and the chemo being better. But to your point, you know, at the end of the day, it is our own cells that have sort of rebelled and started to become cancerous and gone awry. And so we kind of have to, there's going to have to be some collateral damage in terms of trying to treat that. And with chemo, that's unfortunately often the case, although that gets better year by year as we get more targeted and more sort of honed in. You know, it's more of a rifle than a shotgun blast.
Do you think that there can be a cure for cancer, or is that such a big statement because there are so many little components of cancer and so many different types of cancer? Can there be a cure?
So I think that the word cure, you know, with cancer, there are cures with cancer. Obviously, if someone has a breast cancer that is surgically removed and never comes back, well, that's a cure. But I think that for cancers that have been thought of as non-curable, or cancers that that we really don't treat to cure, I think that they're becoming more and more manageable. And that as time goes on, I think there's going to be a lot of cancers that really become more like chronic diseases. And what I mean by that is that we don't treat blood pressure to cure it. We treat it to keep it under control. And we don't treat cholesterol levels to cure high cholesterol. We treat that with medicine to keep it at bay. And I think that with some of the way things are going with cancer treatment now, that's where we're going to be in the next 1 to 2 decades.
Wow. That'd be pretty substantial for a lot of people. That's life-changing. That changes families.
Yep.
Big time. Okay. We're going to take a quick break. When we come back, more of your questions. If you have a question for Dr. Erter, please go ahead and give us a call. 737+ is the number. We're coming right back.